morning, and I wanted to start by thanking you all for the opportunity to serve you during such an important time of change in Maryland. It's my honor. And I also want to thank all of you who have been working so hard during the implementation of healthcare reform here in Maryland. When I came in here, I noticed that there's probably almost a third of the people in the room that I've been working with over the last 2 years. And most of you I didn't know before, so I'm really happy to see really an army of consumer advocates helping us with implementation. This is an unprecedented participation, and it really is what is going to make healthcare reform and work create the value that it's supposed to. And that's really the tremendous benefit to the people who use the healthcare services. And I just really want to say how much I appreciate that engagement that you all have had in this process. And I've been in the position for about 2 years. I met Lenny early on in the process, and I've come from a background of working in a lot of women's advocates organizations, the House of Ruth, Maryland New Directions for Women. I don't know if you've ever heard of that, but that was helping women get to work, from welfare to work. And also a more obscure organization called the Marjorie Cook Foundation, which was funded originally by women who were trying to pass the Equal Rights Amendment. So that one's a little more obscure, but they actually have continued to fund issues like healthcare, where there are equal rights issues at play. When Lenny came up to me after one of our first meetings, we soon got to know each other, and we found that we were exactly on the same page of what we wanted to accomplish. And the consumers have really been at the table in the policy making and in the implementation of the new all-payer model. And it's made a huge difference as we went through the process of making sure that every step along the way, as we developed policies, that we had the consumer in mind. And what I'm going to touch on today really is the evolving healthcare landscape, and Lenny has set some of that stage already. And then talk really about what we're trying to do here in Maryland on a person-centered delivery system transformation around our all-payer model. And then really to connect that to what we need you all to be working on as we try to implement this in the most effective way for Marylanders. Because I'll tell you that the Health Services Cost Review Commission staff is a staff of 37 people, and we need an army of consumers really helping us implement this for the benefit of consumers. So just turning to the landscape that our change is set in, we're stepping back and looking at the national strategy for delivery system change, because our model is derived out of the federal strategy in Maryland. But our Secretary Burwell, our U.S. Health Secretary, has a three-pronged strategy and focused on care delivery improvement to integrate and coordinate care, improve population health, and to promote patient engagement. And also to distribute information, which is a focus on transparency and also bringing health information to the point of care to improve patient care. And also, part of that national strategy is about changing the way providers are paid, moving away from fee-for-service models, which are focused on volumes and do not necessarily promote integration of care, to models that are based on outcomes and value. And Maryland has a unique model in the country. It is an all-payer model. The Health Services Cost Review Commission sets rates for all payers, so there isn't a separate payment methodology for Medicare and Medicaid for hospitals in our state. Every single payer pays the same way, pays on this. We have the same value-based measures and the same outcomes measures, and they pay the same amount. So the social costs are covered by all of the payers in Maryland. And the model that we're implementing now was built on, as Lenny said, it's built on a long history of an all-payer model in Maryland. But it was a new model that was approved January 1 of 2014. And it is the largest demonstration in the United States that's going on from the federal government. We have 6 million people that are involved in our all-payer reform demonstration and 800,000 Medicare lives. So it is, you are helping us with the single largest demonstration, and we really appreciate that. And it is really an unprecedented effort to focus our assets on improving care and improving health and lowering the total cost of care for the benefit of consumers. And we're past our first year of performance, and the first year of performance was very good. We held the cost per capita increase in Maryland to 1.47%, and that was well below our ceiling target of 3.58%. At the same time, we improved on all of the quality measurements that we set forth in our model on hospital-acquired conditions and on readmissions. We had improvements in those and other quality indicators. So in our first year, just to look back just for a minute, the major focus that we undertook was changing all of our hospitals to a new payment model to really enable them to support the delivery system changes that needed to be made. So if they were successful in reducing utilization by providing better care, that they could free up money and invest that in care coordination and additional delivery system transformation. And we spent a lot of time engaging stakeholders in changing our policies and changing our performance measures to drive this new model. And many of you in the room sat on this work group. In the second year, we are now focusing on clinical improvement, and that is focusing on care coordination, care integration, and infrastructure development. And next year, we're focusing on implementation. So a lot of this year has been about planning, and next year is about implementation. So we've been focusing on planning for more consumer engagement and more alignment with providers. And so next year will be, in the next couple of years, will be at implementation years. Now, I just want to now turn and just talk to you a little bit about what we're focusing on doing, and then really how we need to have consumer advocates engaged in helping us reach the strategies that have been set out. And the next few slides have a lot of details on them. I'm not going to go through all the details, but you can get them later. But what we are focusing on is trying to drive the delivery system transformation to tailoring care delivery based on person's needs. And this takes a tremendous amount of change in the system that we deploy today, which is really provider-focused, to make it a person-focused system. And this is at the heart of what we're trying to do. And with the stakeholder groups, we have developed four pillars of transformation that we're undergoing to try to further ourselves in terms of the pursuit of that person-centered strategy and transformation delivery. One is focused on, and each of the four pillars are laid out here. The first one is the state-level infrastructure, and that is with the CRISP, our Health Information Exchange, of getting all of our providers connected to that exchange so that we can have meaningful data be available for doctors at the point of care when they're caring for us in their offices, and also to create actionable tools that will help our care managers with our most complex patients. Secondly, focusing on alignment tools to make changes that will help our physicians and hospitals and other providers organize in a more patient-centered way. Third pillar is care coordination and integration, and the Health Services Cost Review Commission has funded about $200 million in hospitals' rates to help drive the development and deployment of care coordination for the benefit of patients and consumers in Maryland. And last but not least is really focusing on how to engage and communicate with consumers in this process. So that gets to the question of how might these all-payer model developments impact consumers. And so what we're expecting as a result of all of these investments and changes that you're helping us work on is improved data and infrastructure for information exchange, more collaboration among providers, increased efforts to reduce avoidable conditions in the community, so avoiding pneumonia and escalation of diabetes. There's a list of things that we're expecting for the consumers, and last but not least, really, and this is where we really need you helping us, is the increased efforts to involve persons, families, and communities in improving health and outcomes. And I'm going to wrap this part up before we get into questions by saying and asking you for your continued support of this implementation, because, as I said before, we need an army of consumers really helping us realize the potential that we have with this delivery reform and transformation in Maryland. So continued participation in our work groups and keeping us on our toes to make sure our policies are well developed with consumers in mind. Again, Lenny mentioned about the recommendations for consumer engagement and outreach, and continuing to work with us to develop implementation plans and to implement those efforts, because the increased participation from consumers will be critical to our success. And one area in particular that I want to really ask you to help us with is we're putting $200 million into developing care coordination for our state. And we really need you to help us communicate with the consumers about how valuable these assets can be, and to help us bring that to a reality without creating concerns and helping us overcome those concerns as we try to deploy some of these new models for the benefit of consumers. So those are the things that I'd really appreciate your help on to date, and want to ask you to please keep working with us, and thank you. Thank you for all of your participation. And with that, we'll, I guess, turn it and open it up to questions.
I don't want to dominate things here, but I, like Lenny, am on Medicare, and unfortunately had the experience to have surgery this year at 2 different hospitals. My first comment was in the all-payer, and I was one of these big people for all-payer. I really like it. I like what the goals, their system they're moving for. But now I found the hospital gaming. At one hospital, I was not charged, it was in my hospital bill internally, for my physical therapist and my hospice. Your hospice can be a physician, or it'll be a nurse practitioner who's the one, too, that's coming in to make sure that all your issues, all your health care, and I'll give you just a quick example for those who haven't experienced them. For example, you might be in there for a surgery that does not have to do with your heart, but yet you have high blood pressure and some other things. And they didn't do an EKG to look at what was going on with your heart afterwards. So the hospitalist sits in and helps pull the framework together that the whole picture is, which is really a great concept that we have in Maryland. But what happened too, that when I got my bills coming in from 2 different hospitals, my local hospital, everything was included. My other hospital billed separately for all sorts of things. Now I thought, how am I gonna fight this new model, whatever? And I think my message, we know all new models have their problems. So what I did was, in all honesty, my supplemental is United Healthcare. I called United Healthcare because in the end it was gonna cost them more, and the supplemental end of things, and got them to negotiate and take care of the doctors and the physical therapists. So I think it's gonna be something that the Cost Review Commission are gonna have to look at as this model goes into place. What are they transferring to other providers that used to be part of your bill? The other thing on care coordination is the part that if you go out of the region you live in, so for example, I live in Southern Maryland, you travel north to Baltimore, care coordination is not there because the social worker and other people come in and they don't know really your region and county. So one of the things we're gonna have to on this long term, and particularly in the state of Maryland, we're going to have to look at how we do care coordination from our critical hospitals and our specialty hospitals, for the most part, who are all in the Baltimore area. So thank you, those are my comments. It's not like I'm anti it, I just think it's, as we go to new systems, there's more things we have to work on.
Well, amen. There's a lot of things that we have to work on with care delivery transformation, and really connecting data around persons is part of what we're trying to do with a very large investment in CRISP. And so your situation in the future should be that the information will be able to be exchanged better between your hospital and your providers in Southern Maryland. And if you have a care coordinator in Southern Maryland, they might be notified that you've been admitted to a hospital in Baltimore. The hospital in Baltimore will know that you have a care coordinator in Southern Maryland because your care coordinator has registered as one of their patients. And so with this kind of information, there will be a lot more knowledge that can be transferred back and forth so that your care coordinator can get in touch with you either before you leave the hospital or when you get home, to make sure that you're being attended to in your local community, and that the discharge specialist at the academic medical centers or the other institutions can be in touch with your care coordinator to make sure they're helping you in your transition. So I think there's a very, very significant amount of emphasis being placed on developing that resource, because the physicians want that resource, the case managers want that resource, and everybody wants that asset to be working as quickly as possible. So we have a very, very significant amount of change going on with CRISP and a ramping up of CRISP to hopefully bring that reality to you as soon as possible. In terms of billing, I would say that in my 40 years of working in healthcare, billing has always created a lot of complaints. So I don't know that the differences in provider billings are a new complaint. They're a continuing complaint for many, many years of time. But there are things that we are watching, and we have excellent data to help us watch it. But thank you for your comment.
Make your question the last question, Gary, but just to pick up on, so HSCRC has looked very carefully at the right metrics and getting the right data. So that's something as consumer advocates that we're very interested in, obviously, is making sure that those metrics are really, teasing out what's actually happening to the consumer or the patient on the ground when they get to the hospital. The other thing, just on the cost piece, Teresa Lee, who's here from the Maryland Healthcare Commission and is in charge of their website on quality reports, we'll talk about later the resources that are available to help inform consumers about costs, which I think are also very useful. But Gary, sorry.
Hi, I'm a hospital finance guy and have been involved with hospital finances for about 40 years. I'm semi-retired now, and I don't know how many people here appreciate what we have in this state. The all-payer system has been, I didn't spend most of my career here, has been a real eye-opener for me. I thought it was a crazy system when I came here. It just was so different from everything that I had been involved with. And it provides at least an even footing for people who aren't insured and haven't had the opportunity to be involved in groups and those kinds of things when it comes to what it's going to cost them. And so I think we're building on a system here that is different and better. The second comment I'd like to make is that working with the HSCRC, the people who implement this system, has also been a rewarding thing for me. I don't know how many of you know the staff or know Donna and the decisions that she's made to be able to be in this process, but they are the most dedicated people that I'm familiar with in any organization, because most of them have opportunities. They all have skills that would be very marketable, and most of the hospitals would be happy to steal many of the people who are staffers there in order to be able to better operate their processes. So I would like to just offer that Donna and her staff should be commended for their efforts and their approach and their mission in doing this, because I know almost all of them would have a better opportunity to go somewhere else. The other comment that I would make is the system is not well organized and coordinated. You know, if you were an engineer and you designed this kind of a system, you'd probably get fired because it doesn't work well. I've been a CFO most of my life, and I don't understand my bills. When I use healthcare, most of my life I haven't had to use it much, but when I use healthcare, I rely on my wife to figure out what's going on. And then frequently she'll come to me and say, I don't understand this, I've talked to the plan, I've talked to the hospital, what is the problem here? And then I get involved and I look at how difficult it is to understand this for someone who spent their career doing it. And so it really does raise a question about whether our insurance commission should be working with the HSCRC to standardize plans, because I think the plans are so complex, and it is in the insurer's interest in many cases to make it non-understandable. Because many people, including me, I just told my wife last night, go ahead and pay it, it's $30. You know, I know it's wrong, but pay it. We've already talked to them twice about it. It's not worth my time. It was $30 there, it was $13 on the professional side, you know, and this is the second time it's happened in a couple of months, but that's how they win. And you have to remember, many of these are for-profit groups, and what for-profit means is that those people, their duty is not to the service you get. Their duty is to their shareholders or to whoever they're making the for-profit for. And so this is a very complex and difficult system. And Donna and our crew are adjusting it on the fly. And they don't have excellent windows to give them vision as to what's really happening now or to what will happen if they make this a little adjustment here. So I would ask for everyone to be engaged and to have patience, because what we are building towards is something nobody else has had the opportunity to do. And I think, you know, we all come at it from different perspectives. And I know that saying I've spent my career in hospitals is kind of akin to saying I've been an assistant to Donald Trump or something for a lot of people. And so, you know, we speak different languages, we come at it from different perspectives, but I've had the privilege of working on Lenny's group and with Hillary and other folks in this room, and taking those perspectives and talking about them without getting overly emotional, and looking at how come you see it differently from primary care than I see it where I am. What are the incentives that we have built in? And I do believe building in the incentives will change the behavior. If you change how someone is paid and what you are paying them for, you will change what they do tomorrow and the next day and the day after that. So we have to consciously work on making sure that the consumers, who are the ultimate judge of whether this system works or not, stay engaged in the process. And I know it's difficult, because it's very difficult for me to understand what's going on, and I've spent my whole career at it. But I do hope that all of you and the folks that you get engaged with will work with the HSCRC as they develop these new rules and regulations, and not get so frustrated that we give up. Because if you remember what it was like yesterday and last week and the week before, the frustrations change a little bit, but it wasn't perfect then. We have the opportunity to do better, and if we stay together at it, I think we can do that. So, thank you.
And again, thank you all, and I look forward to working with you over the next year.
Thank you.